Good morning, everyone. My name is Shewmake. I'm a third-year medical student at the University of Arkansas for Medical Sciences. Today, I'll be sharing with you our abstract, Improved Confidence in Clinical Application, the Effects of a Longitudinal Suture Curriculum for Medical Students. We have no financial relationships to disclose. Regardless of specialty, many residents are expected to be able to assess and close simple wounds. The American Academy of Family Physicians recommends that residents be able to perform simple excision, incision and drainage of abscesses, aspiration of cysts, foreign body removal, wound closure, and laceration repair and debridement. Harvard Medical School's technical standards for the MD degree state that the candidate must possess the capacity to independently perform the suturing of simple wounds. The ability to suture is not limited to those who go into a surgical field. Lacerations comprise of about 8% of all emergency department visits, roughly 9 million visits annually. These are essential skills, not only when closing surgical incisions and lacerations, but also when placing drains and sewing in catheters. And these skills are utilized by multiple medical specialties, including but not limited to family medicine, emergency medicine, interventional radiology, to name a few. So the need for this skill is there. What are medical schools doing to teach these skills? Halstead's see one, do one, teach one method, while traditional, can be anxiety-provoking, stressful, and arguably unsafe to both the medical student and to the patient. At present, there is no standard accepted method of teaching these skills to medical students. These typically fall in the elective, informal, or peer-to-peer type setting. So as a result, many medical students report feeling unprepared to suture following graduation. This leaves it to residencies to address deficit in suturing skills, procedural skills otherwise. The literature suggests that new skill acquisition is best learned in sequence and stepwise approaches. We hypothesize that students are more likely to gain confidence and practice these skills if they're taught formally, early, and often. So to address this gap in suture education, we introduced a novel longitudinal curriculum for our first and second year medical students to do two things. One, to provide resources to learn basic suturing skills using a suture kit like the one on the screen, and then to build confidence and reduce anxiety when students are asked to perform these skills in a clinical clerkship setting. So what did we do? We implemented a novel 7.5-hour, 5-session suture curriculum with 5-to-1 student to faculty ratios, take-home suture kits, and one-on-one skill checkoffs. To better prepare our medical students for clerkship and beyond, we introduced this program early and often, as you can see on the timeline here. 2 sessions in their first year the fall and spring, 2 sessions in their second year fall and spring, and then 1 5th and final session before they begin their third year clerkship when they're in clinicals. So with the kit and resources described above, they're also given a list of 7 checkoff skills that they're required to check off during this longitudinal course, including proper instrument position, simple interrupted suture, instrument tie, 2-handed knot tying, simple continuous, deep dermal, and running subpaticular suture. The course went as follows. During the first week of medical school, students were given take-home suture kits and online videos where they could practice. Then in the first session on cadaver skin, intact cadaver skin, students were taught skills 1 through 3. Then at the second session in the spring, they were evaluated on those first 3 skills and taught the fourth skill. They were also evaluated one-on-one by a preceptor and remediated as needed. So the third session was held in the fall semester of their second year in the gross anatomy lab. Students were evaluated on skills 1 through 4 this time, taught skills 5 and 6. And the fourth session was held in the middle to the end of their spring semester, where students were provided pig's feet and they were individually evaluated on skills 1 through 6 and introduced to skill 7. The 5th and final session, just before the beginning of their third year of medical school, during this boot camp, students demonstrated proficiency on all 7 skills with a final evaluation of competencies. As you can see again on our timeline, we surveyed students before they began the session, immediately after the first course, and then at the end of their third year of medical school, so after they'd had a year of clinical clerkship. So what did we find? In our pre-course survey, we wanted to get an understanding of our incoming medical school class. What experience did they have with suturing and this kind of procedural skill? And as you can see here, only 4% of students had sutured previously. 59% of students reported that they had observed suturing, and 37% of students had no previous suturing experience. Looking at the post-course survey, so immediately after that first skill session, you'll note improved student confidence in performing the 3 skills that were taught: proper instrument position, simple interrupted suture, and instrument ties. And this was to significance. Moving along to at the end of their 3rd year. So they had gone a whole year without a curriculum class at this point. Those confidence gains were sustained through their clerkships to significance in those 3 skills. So digging a little deeper, of those who completed the post-clerkship survey, 2/3 of participants reported feeling very or completely prepared to suture. 83% of 3rd-year medical students successfully sutured without the need for significant direction or guidance. This is very different from the previously reported statistic about students not feeling prepared to suture upon graduation. So the primary objectives of our curriculum were to provide resources to learn basic suturing skills and to build confidence and reduce anxiety when students were asked to apply these skills during clinical clerkship. This study shows through formal iterative suture training, students report increased confidence and preparedness for clinical clerkship, requiring less guidance overall when performing these skills. This project is of special importance to a university like ours, where 60% of practicing physicians in the state of Arkansas were trained at the University of Arkansas for Medical Sciences. UAMS serves a rural state. We're 47th in the nation in active physicians per 100,000 people. According to a Kaiser Family Foundation study, over 1/5 of Arkansans live in a health professional shortage area. Our Arkansas Department of Health says that 67% of our counties are either fully or partially designated health professional shortage areas. So you can see that it's especially important for us to train students of all specialties to perform these skills in areas of need, to be competent and confident in their abilities to do so. Any study that is survey-based will have a certain level of subjectivity. Opportunities for improvement with this project moving forward. We would like to implement a more formal assessment of skill, whether that be a practical or a quiz pre or post this study. We would also hope, again, with a survey-based study, attrition is a difficult thing, to increase response rate to studies, to our surveys. And then a control group, as this was an educational tool, we didn't want to offer it to only a subsection of our medical school class. So what we would like to do ideally moving forward is to look at our alumni who had access to this course and compare them to those who did not and see how they're using these skills in the future. We would also hope to look at skill retention moving forward as well. So our results demonstrate that a longitudinal formal suturing curriculum significantly improves student confidence and increases their preparedness for clinical clerkships and suturing skills. These results emphasize the importance of a structured longitudinal curriculum for medical students to learn basic suturing skills, to better prepare them for clerkship, residency, and one day, we hope, the needs of their patients. These are our references and our acknowledgements. As this was a longitudinal study, it was also a longitudinal project. We have a lot of people to thank for making this possible, and many instructors who took apart their time to set aside their time to spend time with students and teach us. Thank you all very, very much. What questions do you have for me?
Did you ever suture on cadaver or
We did suture on cadaver. Yes, ma'am. We had 2 sessions where we suture on cadaver. The first one, the introduction session, and then I believe the 3rd session as well.
Other questions? Okay, Dr. Campbell.
Why do you postulate less than half of the original cohort completed the post survey?
I think that, thank you for that question. One thing is that we do lose some medical students as they go through their training. So that's part of it. I couldn't tell you with this cohort how many we did lose. But what I would also say is we implemented this program around the same time of COVID. And we think that that may have played a role in some of our low response rate towards the end.
I just remember a chance to sow is a chance to grow. You know, one of those see one, do one, teach one.
Question in the back.
information. One question, one comment. The question is, did you all ever consider looking at maybe surgery evaluation comments for students that do their surgery clerkship first to see if they comment more on increased suture skills or better ability to do that, across their clerkship? And then two, just consideration that, I think this would be a great project for you all to consider putting in something like that for.
Okay, thank you. Absolutely, it is something we want to look at, the surgery evals. One thing that prompted this program in general was that the surgery clerkship directors noticed that students had varying degrees of skill. If you're more interested in a surgical field, you may be more likely to pursue those opportunities. And that's where those elective informal, I would go to the M4 who's done it and ask them. And that kind of created this disparity between those who knew how to suture and those who did not. So this was kind of a way to, as we can see, many fields, not just surgical fields, use this. So I agree. I think moving forward, it would be good to look at, has there been a change anecdotally in the comments given? So thank you.
Oh, I can see there's one right next to me. So what percentage of the med students were enrolled in this?
So our incoming class is typically 174 students. Our initial response rate to the first study was 166. So that was our first cohort. And is it okay if I go back to that slide? Okay. Let's see. Okay, so you can see the loss of people, after their third year. Maybe they didn't want to fill out the survey. They're done with their third year clerkship, whatever you have it. But so you can see in our pre-course, we only had 166 out of 174 to
And
begin
did they
with.
all complete all of the sessions?
Yes.
Okay,
Mhm.
so one thing that's tricky here that I'd suggest in going forward,
Mhm.
because like you said, others have noticed that there was an issue. So others might be attempting some form of intervention as well.
Mhm.
If you somehow either split them into a control group or something you can't do if you'd gone back in time and given the same survey in years prior to it. But again, that wouldn't account for any changes that people are making as they go. So just a thought on moving forward, since there might be others intervening, to say, hey, what if we only offer it until we fill X number of spots and then try and get surveys from both groups?
Yeah, no, I think that's a great idea. Thank you.
Other questions? All right. Thank you.
All right, thank you all.